Hello, students. Welcome to this class. I'm going to take you to the Pediatrics INICET Recall Exam papers. So, next another 50 to 55 minutes, I'll be discussing the some of those questions has been asked in the INICET exams related to pediatrics. So, I also request you to write up your queries, doubts in the chat box as we go through these questions. So, what do you feel is the question paper is related to pediatrics is difficult or tough? I think looking into the question paper looks to be a good one and easy to score compared to the other subjects. So, let us go to the questions. First is the first question is which factor does not cause fetal growth in utero? Just a minute. The first question is which factor does not cause fetal growth in utero? The answers are there with us insulin, growth hormone, IGF-1, thyroxine. What do you feel? So, here remember that the no steroids hormones has any growth and do not have any effect on growth, which is not given here, but I'm just informing. So, what about the insulin? Insulin is produced by the fetal pancreas and which is in response to the nutrient supply. So this is which is responsible for the growth of the baby, so which is necessary. So what about IGF-1 and IGF-2? These are usually produced by the placenta. They also responsible for the growth of the fetus. Thyroxine, if you see the T3, T4 is a maximum which is present in the maternal circulation, process the placenta, which is required for a fetal neural development. And a fetal thyroid produces the hormone by around 12 weeks of gestation onwards. So, to a certain extent, fetal thyroxine is also responsible, but the growth hormone, even the growth hormone is an important hormone, but it has no effect on the growth of the fetus. So, here the correct answer is the growth hormone. So, let us go to the next question. The question is from the neonatology. Ensure. Ensure means IN is correspond to intubation. SUR, which means that surfactant administration into the fetal lungs. And E is extubation. So this is called as, the technique is called as Ensure technique. And this is used in a preterm neonates anywhere between 24 weeks to 34 weeks of gestation and even little later to instill a surfactant into the baby's lungs, and specifically in a condition called as the respiratory distress syndrome or surfactant deficiency or hyaline membrane disease. So the answer is here respiratory distress syndrome. The next technique, sometimes other than the Ensure, the other technique is also called as the LISA, which is presently we use this technique called as less invasive surfactant administration. This is also used to administer surfactant into the baby's lungs through the endotracheal tube, or some of these devices which goes the or even the infant feeding tube which goes into the trachea, or sometimes we also called as this is a mist technique. So these are the ones used for a surfactant administration for the baby's lungs to treat the surfactant deficiency or hyaline membrane disease. Next, again, the question from the neonatology, a dose of antenatal steroids. Antenatal steroids are used between from 24 weeks of gestation to 34 weeks of gestation. Below 24 weeks of gestation, the role of steroid is controversial or may not make much of a benefits, whereas 34 weeks and beyond, the surfactant administration may not required because this is the baby's lungs are already developed. So now we have two drugs, that is the dexamethasone as well as the betamethasone. So remember 24 to 34 weeks of gestation. So the dose is generally it is a 6 milligrams of a dexamethasone given 12th hourly for 2 days. That is totally 24 milligrams at least 24 hours prior to a delivery will help in the surfactant production by stimulating the type 2 pneumocytes in the baby's lungs. So what about this is the right answer here. So what about the betamethasone 12 mg 12th hourly? Betamethasone 12 mg is correct. The dose is correct, but it should be given 12 mg Q24 hourly, and again 2 doses. Dexamethasone 12 mg, again not the correct answer, and dexamethasone 6 mg 24th hourly, not correct answer. So remember, it is a 24 milligrams of a dexamethasone or betamethasone which is given 24 hours prior to delivery in a 24 to 34 weeks of gestation where a threatened preterm deliveries are there, which helps in the baby's lung development. So let us this is called as antenatal steroid. The other drug along with the steroid used is the magnesium sulfate. This is used for a neuroprotection. And again, this can be used from 24 weeks of a gestation to around 34 weeks of a gestation. Generally, it is given as a 4 gram as a loading dose and then given as a 1 gram per hour as a infusion. Now, how does the magnesium sulfate benefits the baby? You can remember neuroprotection here, minimize the risk of a intraventricular hemorrhage or periventricular leukomalacia. Two comorbidities in a preterm neonates are classically they are intraventricular hemorrhage and second thing is the periventricular leukomalacia. So which can be minimized with giving this drug. And some of the centers, advanced center, where the monitoring facilities are there, they use magnesium sulfate in addition to a steroid in a threatened preterm delivery. So the next question, the free flow oxygen can be given in a neonate by all except. And the answer is given here self-inflating bag, or we call it as in a MCQs distractors, TP's resuscitator, face mask are firmly over mouth and nose, tubing over mouth and nose. Now, let us look into this. So, this is the so if you can see here, this is a extremely sorry for that some delay here from my side. This is a self-inflating bag. Remember that unless we give a positive pressure ventilation, the air do not come in. Whereas this is called as a T-piece resuscitator, where there's a free flow of oxygen is there. And then we have other things here This is called as a facial mask is there. And addition to that, a free flow tubing is there. So here the correct answer is the free flow oxygen can be given in a neonate by all except is a self-inflating bag. Even though we know that self-inflating bag is a bag which is used for resuscitation unless we inflate the bag or deflate the bag or give a kind of a the, the inflate the bag. So unless we do this, free flow oxygen cannot be given to the baby, which means that if I have a bag and which kept over baby's face, and then if I'm inflating and deflating continuously, then only there is a free flow of oxygen will be there. Otherwise, there is something called as a fish mouth valve is there in a self-inflating bag, and which is usually present in this portion. If you can see, I'm circling here in this portion, and this prevents a flow of air from one direction. So unless I compress this bag, then only I can give a free flow oxygen to the baby. So we know that, in fact, I have covered up in earlier my classes regarding the newborn resuscitation. That is, give a breath and save a life. And these are the campaigns which is there, which is used for a newborn resuscitation. But here the question is very tricky here. So free flow oxygen, unless we compress the bag, the air does not goes to the baby. So the correct answer is here, the self-inflating bag. So next we go to the other set of, these are the neonatology questions which has been asked in the exams. Let us go to the pediatric set of questions. So first question here is, which of the following is not true about a febrile seizures? The answer is here, the non-febrile seizure has a recurrence of a 54%. If you see the correct answers about the febrile seizures and not about the question here, which is seen between a 6 months to 5 years here, but extended sometime febrile seizures can be present even up to 6 years to a 7 years of age. They are simple, a generalized or tonic-clonic seizure which lasts less than 15 minutes and single episode in a day are not associated with a post-ictal confusion or neurological deficit. They do not require any long-term anti-epileptics, and these are called as what is called as a simple or classical febrile seizures. Whereas atypical febrile seizures, where fever may be present, but classically the age may not be the fitting one there, and they are focal seizures, multiple episodes, and they may be associated with the focal neurological deficits. And there, the any of the febrile seizure, the recurrence rate is less than 20%, whereas non-febrile seizures, the recurrence rate is slightly lesser than that. So the correct answer is here, non-febrile seizure has a recurrence rate of 54%. And remember here, we do not use any anticonvulsant for to treat febrile seizures. The medication used are either the nasal, that is a midazolam spray, nasal spray of a midazolam, or sometimes we use a per rectal diazepam also to break the cycle, but this is an old outdated practice. But any benzodiazepines can be used orally for 48 hours as a seizure prophylaxis. and not a seizure medications. And prompt treatment of a temperature, reducing the temperature is necessary. So going to the next question, the spastic quadriplegia seen in a child, periventricular leukomalacia, cystic encephalomalacia, basal ganglia calcification, cerebellum degeneration. The answer is here the cystic encephalomalacia. Periventricular leukomalacia are classically seen in a preterm babies, and this is known to cause a spastic diplegia. And such children are intellectually they are near normal. So periventricular leukomalacia is not the reason for a spastic quadriplegia. Cystic encephalomalacia, or this is also called as porencephalic cyst, and classically in a spastic quadriplegic baby, we have something called as microcephaly also. So microcephaly and spastic quadriplegia always goes together. And this is classically seen or underlying neurological problems or malformation is a cystic encephalomalacia. Basal ganglia calcification or involvement of a basal ganglia can lead to into a something called as chorioathetoid CP, okay, and may be seen in a children of following a kernicterus or bilirubin encephalopathy. Cerebellar degeneration can lead to a ataxia, or this is also called as ataxic cerebral palsy. So answer is here cystic encephalomalacia. Some of the literature may give you the answer as a periventricular leukomalacia. Remember, periventricular leukomalacia is known to cause a spastic diplegia and not the spastic quadriplegia. The next question is, which of the following is not a feature of a Kawasaki disease? In fact, the Kawasaki disease is one of the presently is most common acquired heart disease in pediatric age group. Earlier it was the rheumatic heart disease, but rheumatic heart disease incidence has significantly reduced over last few years, specifically the last decade. But now we keep seeing Kawasaki disease. So strawberry tongue is commonly seen along with the desquamation of the palms, soles, or skin. Polymorphic rashes are seen in these children. Cervical lymphadenopathy is also seen. Purulent conjunctivitis is seen. Conjunctival congestion is seen, but not the purulent conjunctivitis. It is the non-purulent conjunctivitis. The moment purulent conjunctivitis, remember that it is something lead to a bacterial or infections. So this is answer is here non-purulent conjunctivitis, but here it is purulent conjunctivitis, so which is not a characteristic features of a Kawasaki disease. And one of the complication what we get in a Kawasaki disease, as I mentioned, it is one of the most common cause for a acquired heart disease in the pediatric population nowadays. It is known to cause coronary aneurysms and long-term complications related to a coronary aneurysms. So the next set of questions is of feeding. Which of the following are the components of Down score? And here given a combinations: the respiratory rate of feeding, grunting, and cyanosis. And the answer is here, the respiratory rate, yes. Grunting is yes. Cyanosis is yes. So it is a 1, 3, 4 is the correct answer. Now this is called as the Downey scoring. Downey scoring has got a 5 components. They are called as respiratory rate, the chest retractions, cyanosis, air entry, and grunting. And the score is given 0, 1, and 2. If the respiratory rate is less than 60, score is 0. 60 to 80, score is 1. And more than 80, a score is 2. Retraction none, 0. Mild retraction is 1. A significant, a marked or severe retraction is score is 2. Cyanosis none, which means that baby do not have a cyanosis. Fast breathing is there, tachypnea is there, score is 0. Cyanosis related, but oxygen around 40% reduces the or relieves the cyanosis, is a score is given 1, whereas more than 40% of oxygen is required, or despite the oxygen cyanosis is persisting, score is given 2. R entry is good, score is 0. R entry is decreased, score is 1. A significant R entry in the lungs is reduced, score is given 2. R entry, grunting, no grunting is 0, whereas the audible with the a stethoscope, the score is 1, and the grunting is audible without the stethoscope, which is the score is 2. So totally the score is 10 here. And remember that any score more than 5 total score indicate that there will be a chances of a respiratory failure, and such children requires a ventilation. Some question I'll be taking up here, which is given in the chat box. A free flow oxygen, one option was face mask tightly over face. Should not that be incorrect? I think it is a face mask tightly over the face gives the oxygen to the baby. In fact, it gives a more concentration of a free flow oxygen to the baby. If it is a snugly fitting a face mask over the face, which gives a less concentration of oxygen. So I don't think that is the right answer. Is also uh, is given why we would place on face, and that too loosely. So we have to keep on mouth and nose. All option had mouth and nose. So face mask basically covers the a part of a chin, mouth, and nose. So this is how it covers. So remember that. So as I mentioned, it is a fitting snugly, which means that there is no loss of oxygen or air from the tubings their side. So the more concentration of the oxygen is given, whereas a loosely fitting, there is a loss is there. So we there is free flow is there, but some of loss is there. In fact, the concentration of oxygen given is less here. So so I'm not sure about the distractors what is given there, but of face mask loosely or tightly, both will give a free flow oxygen to the baby. Remember that. Okay. But when you here question is the free flow oxygen. But when you're giving a bag and a mask, remember that it has to be tight. So that's why it is called as only when there is a tight bag and mask, then only the when you compress the bag, the air is going into the lungs. So that's why if you remember the mnemonic MR SOPA, which I covered up in my resuscitation, MR is mask, reposition. So mask and reposition, these we took together. If it is a tight face, put a mask and then compress, the air is going to the lungs. But if it is a mask is loose here and we compress, the air is not going to the lungs. So remember that face mask, either loosely or tightly, they give a free flow oxygen to the baby. If you're giving a bag and mask, then it is tight face mask. Remember that. So that's why I think it is, that is what the distractors are given for that questions. Somebody asked, what about tubing held close to the nose? Again, free flow is there. Remember. So earlier courses we used to teach, if it is kept somewhere very close to the nose, we used to give around 60% of the around 1 inch, around, if a tubing is kept 1 inch, around 2 liters of oxygen or 1 liter of oxygen gives around 60% of oxygen, and around 2 inch it is kept about, it gives about 40% of oxygen. These are all old teachings. In fact, there is a no role to give a free flow oxygen to the baby. Only thing is free flow oxygen can be given when the baby is breathing and spontaneous breathing is there, heart rate is good, then only free flow oxygen is given. If the baby's heart rate is less than 100 or babies has got a cyanosis, then there's no point in giving a free flow oxygen. It has to be given the bag and mask ventilation. So I think there's a lot of questions given here. Answers have been, the questions has been asked here, but remember that is the question which has answered. I hope I have answered. The next question is watering photophobia in a 2-month-old neonate, not a cause. Nasolacrimal duct obstruction, a glaucoma. Answers are given. And then entropion, dystiasis. Here, the answer is nasolacrimal duct block. Reason is nasolacrimal duct is only responsible to give a watering, but no photophobia. Whereas all other things, that is glaucoma, entropion, they all responsible for a photophobia. So here the correct answer is NLD block. Okay. So I hope this is a many of you have done correct with this answer. And these are that's what I told. Few of the questions are straightforward and easy for answering. So let us move forward further. Head circumference increment in first 3 months of neonatal life. So answer is given 0.5 centimeter per month, 1 centimeter per month, 2 centimeter per month, and 4 centimeter per month. The correct answer is 2 centimeter per month. So usually the first 3 months, so 0 to 3 months, it is 2 centimeter per month the head will grow. 4 months to 6 months, roughly 1 centimeter per month the head will grow. Seventh month to 12 months, we expect a 3 centimeter totally, or around 0.5 centimeter. And then first to second year, we expect another 3 centimeter. So we expect a baby's head circumference to be around 33 to 35 centimeter at birth, and then we expect around 41 centimeter around 3 months of age, roughly about 44 around 6 months of age, of 47 centimeter around 12 months of age, and somewhere around 50 centimeter is around at 2 years of age. So the correct answer is the first 3 months, the head circumference is at 2 centimeter per month. The next question is a 15-year-old child has a short stature. Height is 145 centimeter. Upper segment, lower segment ratio is zero point 0.8 to zero point 0.1. And what is the diagnosis? So here, if you see the upper segment, lower segment ratio, if we see where upper segment, lower segment ratio is maintained. And that is what we have to see. If you see at birth, the upper segment to lower segment ratio is about 1.7 is to 1. So around 1 year of age, the upper segment to lower segment it comes to 1.5 is to 1. At 2 years, it is 1.4 is to 1. At 3 years, it is 1.3 is to 1. And around 4 to 5 years, it is around 1.2 versus 1. And between around 6 years, it is around 1.1 versus 1, which means that the lower segment is increasing in size, the upper segment is reducing in size, and around 7 to 8 years of age, we expect the upper segment, lower segment to be equal, and more than 10 years, the upper segment is a shorter and the lower segment is a higher. So if you see here, so the spondyloepiphyseal dysplasia is a correct answer here because the the height is short here, but upper segment and lower segment ratio is maintained. So the correct answer is here spondyloepiphyseal dysplasia. So next we'll go to the another question which is not true regarding rotavirus vaccine. So remember, rotavirus is a live vaccine. First, remember that it is a live vaccine. It is given orally, and the first dose has to be given within 6 months. So, if you see here, it is not started after 6 months. Yes, rotavirus should not started after 6 months. 6 months. It is given orally. Yes, it is given orally, and there are both monovalent and pentavalent variants are available. In fact, the dose is sometimes the Rotavac is somewhere around a zero point 0.5 ml, whereas Rotacil, the dose is around 2.5 ml. The dose differs. So it is not a subunit vaccine is a wrong answer. In fact, there's a correct answer here, whereas others are true for rotavirus. So it's a live vaccine. It is a monovalent as well as the pentavalent vaccine. It is given orally. It should be started before 6 months. The dose could vary, depends on the brand, maybe a zero point 0.5 ml to a 2 ml, 2.5 ml. And one of the most important complication related to a rotavirus vaccination is interception. So I hope most of you are return this question as correctly. Now next is this is as I think has been already discussed by the ENT staff here earlier, but since it is common to pediatrics as well as the uh, ENT, I'll be just discussing this question. Child with bilateral sensory neural hearing loss, which of the following will not be done? Cochlear implant definitely benefits. Sitting in front row of class, yes, may benefit. Hearing aid may benefit, but I don't think we should do a adenoidectomy and chromate insertion. So this is the correct answer, which should not be done for a child with the bilateral sensory neural hearing loss. So this is another important question. There are a lot of questions being asked in every exams related to a nutritional rickets or rickets. In fact, this is a very common problems we see in our day-to-day practice also, specifically in a developing countries like us, developed countries. The nutrition is good, vitamin D supplementation is good, so we do not see. So what happens in nutritional rickets? Normal calcium or low calcium may be seen. Yes. What about the, so what is not seen here? Low phosphate. Yes. Phosphate levels are low. Calcium could be normal or low. And we also expect ALP. In fact, the workup which is required for a rickets is a biochemically calcium, phosphorus, ALP, and maybe we can ask parathyroid hormone also sometimes, and the x-rays of a wrist or knee joint are asked for a confirmation. So high levels of parathyroid is seen, which is right. Low phosphate is seen, which is seen in a nutritional rickets. Normal calcium is also seen, or sometimes low calcium is also seen in a um, nutritional rickets. But urine calcium creatine ratio of more than 15 is not seen. So the right answer is here. This is the right answer. Let us go to the next question here. Multiple answers could be correct. Hemophilia B, we know that it is a factor 9 deficiency. So cryoprecipitate can be given, fresh frozen plasma can be given, factor 9 can be given, factor 8 can be given for a factor 8 or hemophilia. So this here, the questions, multiple answers could be correct. Next is the best indicator of some dehydration in SAM. Now, this is a very tricky question because SAM itself has got a lot of factors which is very overlapping with the dehydration. Now, if you see a severe dehydration, here it is some dehydrations, remember that. So there will be a decrease urine output or decrease frequency of urination. Sunken eyes, yes, we see both in dehydration as well as the SAM, severe acute malnutrition. Thirst, initial stages, thirst is present, but as the child worsens, the thirst may be impaired, the child may be more lethargic also. And in addition to that, in a severe acute malnutrition, remember this child is more lethargic. So I'm not sure this child will have a thirst. So delayed skin pinch is again seen in a severe acute malnutrition. That's why this is not a very reliable sign of a dehydration in a severe acute malnutrition. So here the right answer is sunken eyes. Even though it is present in a dehydration as well as the severe acute malnutrition, but sunken eyes may give a more clue in a child with a severe dehydration with the severe acute malnutrition. So I feel this may be a right answer here, or thinking that this child, the activities or behavior is normal, and we know that some dehydration will have a good thirst, and so this may be also right answer. So I strongly feel this is little a more trickiest question given in that. So sunken eyeballs may be the right answer according to me. So let us move to the subsequent set of questions. A fluid solution preferred in pediatric patient. I think it is a pediatric resuscitation. It is. I think it's a question. This one word is missing. Pediatric resuscitation patients. So all resuscitation, remember it is the solution used is ringer lactate or normal saline. So these are the correct things are being used. So here the question, the most closer to the answer may be normal saline with the dextrose. But remember, the normal saline is only the use, but with the not dextrose. So I feel that either the stem is correct or the distractors are correct. If the distractors are correct and most closer to the answer, to the right answer is, as I mentioned, the ringer lactate or normal saline. So it is the most preferred solution is here, normal saline. Okay, normal saline plus minus dextrose, which is given here. So I would answer as a normal saline. So next is the indication to start a steroid therapy in IgA vasculitis in children. It is a severe skin rash, arthritis. It is basically a severe abdominal pain, which is used here. Reason is to prevent the intussusception. Intussusception is a common complication associated with IgA vasculitis. So severe abdominal pain, which is going towards the vasculitis, may be the correct answer here. And so let us move to the further questions. A 5-year-old child present with symptoms of mild to moderate dehydration. You are evaluating the clinical signs, confirm the diagnosis. Which of the following signs are not consistent with some dehydration in a child? Decreased urine output, lethargy, delayed skin pinch, sunken eyeballs. I have already answered these questions in my previous question. That is, remember that decreased urine output will be there in a moderate dehydration. I think it is a question is moderate dehydration, not a mild dehydration. Something wrong in this question here. So delayed skin pinch is there, sunken eyeballs is there. So anything related to 1, 3, and 4 is the right answer. So let us move further. A 10-year-old boy present with the SMR stage 5, which means that he is the the gonadal development or sexual maturity has advanced. He has got a blood pressure 150 by 90 and with the hypertestosteronism, which is the enzyme deficient here. And the correct answer is here 11 beta hydroxylase. So 21 beta hydroxylase classically leads to a congenital adrenal hyperplasia, which is known to be associated with the virilization, and that is seen in a newborn babies. And this is an adolescent, is going to be a pre-adolescent stage. Already advanced, the development is there, gonadal development is there, and here answer is 11 beta hydroxylase deficiency. So the next question is, a 5-year-old child has the following anthropometry. Weight for age is less than minus 3.2 standard deviation. Height for age is minus 2.5 standard deviation. Weight for height is less than minus 1.7 standard deviation. Is it acute malnutrition? Severe acute malnutrition? Remember, acute malnutrition, only the weight is reduced, minus 3 standard deviation, whereas severe acute malnutrition, we can expect both are less, that is the weight for age is less, and weight weight for height is less than -3 standard deviation, and mid-arm circumference is less than 11.5 centimeter. So chronic malnutrition, remember both weight is for age is reduced, height for age is reduced, and they are proportionate. Here, not proportionate. Here, they are disproportionate. So the correct answer or closer to this answer is acute on chronic malnutrition. So the last question I'm going to take up here today is the all are true about a renal tubular acidosis in children except rickets is seen in Fanconi syndrome is one of the answer. Hypokalemic with paradoxical aciduria type 4 or type 4 RTA is given. Type 2 RTA where abnormal excretion bicarbonate excretion is given, and type 4 is aldosterone deficiency. I think somewhere this distractors are not correct distractors, whatever given in this. So I'm not going to discuss, but remember that type 4 is classically hyperkalemic. So the right answer is here. It is hypokalemic with paradoxical aciduria or is seen in a type 4 RTA. So these are the few questions has been asked in the your INICET exams related to pediatrics, and I have covered few of the questions here. So and I have tried to answer few of the questions. I mean few of the chat box. Some of those questions. If anyone has got any questions related to whatever I asked, so I'm ready to answer. The few questions are there by Dr. Abdul Hanan has asked, no resuscitation. I think it is only fluid. If I go back to that question, fluid resuscitation preferred in pediatric patients and no resuscitation. So in that circumstance, the most preferred fluid, normal fluid, what we say is a isolite P. That is a pediatric maintenance fluid. Okay.